Good evening, respected Professor and my dear students. I welcome you all to our RISA online academic activities for the DNB students. Today we have theory questions answering session. First, I invite Dr. Simone from Jagjivanram Hospital, Western Railway, Mumbai. She will be presenting the answer for question define and classify dead space ventilation, the clinical importance of dead space. Over to Dr. Simone.
Good evening, everyone. Am I audible?
You are
Yes,
audible.
Okay, good evening. My topic for today is dead space ventilation. So the definition, dead space refers to the part of tidal volume that does not take part in gaseous exchange due to lack of perfusion. So in a normal healthy adult, such dead space contributes to approximately 1/3 of each tidal volume, and this increases with age. Now, the part of tidal volume which actually takes part in gaseous exchange in the respiratory bronchioles and alveoli is called as alveolar ventilation. So, we can conclude that tidal volume is a sum of alveolar ventilation and dead space ventilation. Now, factors affecting dead space. So, the factors which increase dead space are age, upright posture, maneuvers like neck extension, positive pressure ventilation, neuromuscular diseases, drugs like anticholinergics, low cardiac output states like congestive cardiac failure and blood loss, COPD, and pulmonary embolism. And factors which decrease dead space are supine posture, neck flexion, and use of artificial airways. So coming to the types of dead space can be classified into four broad types. The first is anatomic dead space. So anatomic dead space is the volume of air in the conducting airways which does not take part in gaseous exchange. So this includes the part of tidal volume occupying right from the lips or nares to the pharynx, larynx, trachea, and bronchi up to the respiratory bronchioles. In general, the volume of anatomic dead space is around 2 ml per kg of the ideal body weight, which amounts to approximately 100 to 150 ml. This anatomic dead space represents the volume of air contained by the conducting airways, so it is normally fixed and it cannot be reduced except in situations like tracheostomy. Anatomical dead space increases with large inspiration due to radial traction on bronchi by the surrounding lung parenchyma. It also increases with maneuvers like neck extension and jaw protrusion. Then the second type is alveolar dead space. So alveolar dead space refers to the alveoli which are being ventilated but not perfused, so thus they are unable to take part in gaseous exchange. Alveolar dead space is obtained by subtracting the anatomical dead space from the physiological dead space. In a normal healthy adult, alveolar dead space is negligible, but it becomes significant in certain disease states. For example, when there is over-distension of alveoli in patients of COPD, when there is reduced perfusion in low cardiac output states like heart failure or blood loss, and obstruction of pulmonary blood vessels due to vasoconstriction or pulmonary embolism. Coming to the third type, that is physiological dead space. This is actually the sum of anatomical and alveolar dead space. So it is the total dead space. In healthy individuals, since alveolar dead space is negligible, physiological dead space equals anatomical dead space. However, in diseases with raised ventilation perfusion ratios like COPD and pulmonary embolism, alveolar dead space increases. So here the physiological dead space will exceed anatomical dead space. Then the last type is apparatus dead space. So apparatus dead space is the dead space volume contributed by the use of airway equipment. It is the volume of anesthetic equipment that is filled with exhaled gases at the end of expiration. In a non-rebreathing system, this volume will be re-inhaled in the next breath. And in a closed system, this volume will be re-inhaled without passing through the CO2 absorber. So it is the volume of breathing system from patient end up to the point where inspired and expired gases meet and are separated. In an afferent system, the apparatus dead space extends from patient end up to the expiratory valve, whereas in efferent systems, it extends up to the fresh gas inlet. In circle system, it extends up to the junction of Y-piece connector. So all these hold true only when we have adequate fresh gas flow. If not, then the dead space will increase further. Additional airway equipment like the use of face masks and catheter mounts further increases the dead space. So this apparatus dead space normally amounts to about 50 to 100 ml. Now coming to the importance of dead space. So like we discussed that tidal volume is a sum of dead space and alveolar ventilation, and there is a ratio of dead space to total to tidal volume. Since dead space is usually 1/3 of the tidal volume, the ratio of dead space to tidal volume is 0.3. But any reduction in tidal volume causes a higher dead space to tidal volume ratio. So if the tidal volume reduces from 500 to 300 ml, the dead space to tidal volume ratio will increase from 30% to 50%. This is because anatomical dead space remains constant. So this is important because it represents how much of the tidal volume is actually involved in CO2 elimination and the amount of ventilation which is being wasted. Now, maintenance of PaCO2 is a balance between CO2 production, which is a reflection of metabolic activity, and CO2 elimination via alveolar ventilation. If minute ventilation is constant and dead space increases, then alveolar ventilation will be reduced and the PaCO2 will start rising. Thus, we can conclude that elimination of CO2 is inversely proportional to the dead space volume. Pulmonary diseases result in an increase in alveolar dead space. This triggers an increase in minute ventilation to maintain PaCO2 levels, which is mainly accomplished by an increase in respiratory rate. In pulmonary embolism, when perfusion to a large number of alveoli is interrupted, the dead space to tidal volume ratio can exceed 0.8. In this case, to maintain normal alveolar ventilation, the minute ventilation also increases, and this leads to significant dyspnea, which is in addition to the dyspnea caused by a decreased PaO2. In COPD, there is diversion of the inspired air into distended alveoli, which are ventilated but poorly perfused. This leads to locally raised ventilation perfusion ratios, equivalent to an increase in dead space to tidal volume ratio. In severe COPD, the dead space to tidal volume ratio may increase up to 0.9, and the patient has to hyperventilate massively to maintain a normal PaCO2, which is not possible where ventilatory reserves are diminished. These patients have reduced alveolar ventilation despite an elevated minute ventilation. Over a period of time, compensatory mechanisms develop to maintain a stable rate of CO2 excretion with lower level of alveolar ventilation, and then these patients get accustomed to raised PaCO2 levels. Coming to the importance of apparatus dead space, so rebreathing of apparatus dead space does not contribute either to heating or humidification of the inhaled gases, but it can reduce alveolar ventilation because it does not contribute to CO2 elimination. Apparatus dead space contributes significantly to rebreathing in neonates. Thus, minute ventilation needs to be proportionately increased in such patients to ensure adequate gas exchange. It is also encouraged to have minimal connections in circuits for neonates and pediatric patients so as to reduce rebreathing. Thank you.
Very good. Can you switch on your video to show your face for a second?
Yes, sir.
Very good. Thank you very much. It was a very, very lucid, very beautifully described presentation.
Thank you, sir.
But as a teacher, I have to find fault in any presentation. Then only the teacher's job is completed. You agree or not?
Yes, sir.
Yes. Okay. Can you just repeat the definition first you started with? What is the definition of dead space?
Sir, dead space refers to the part of tidal volume that does not take part in gaseous exchange due to lack of perfusion.
Yeah. Now that last addition, lack of perfusion, does it hold good to the anatomical dead space?
No, sir.
The area of the respiratory tract where the anatomical dead space gases are there. Do you think they are not getting their blood supply? Then how will the trachea, bronchi, all these things will survive? They have their own perfusion and blood supply, no, for their maintenance, their normal metabolic activity.
Yes, sir.
Right. So the word perfusion refers only to the area for alveolar ventilation. If there is no blood supply in the pulmonary capillaries which are subserving the alveoli, and only air is going into that particular alveoli, then it becomes a wasted ventilation because there is no blood to take the oxygen or remove the carbon dioxide into that alveoli. So for alveolar ventilation, this definition of yours will correctly fit in as there is lack of perfusion. But when it is anatomical dead space, this lack of perfusion is not the correct terminology to be used there. So what you can do is the definition of dead space is the part of that part of tidal volume or the air that is not taking part in gaseous exchange. You can stop there. You need not add that due to lack of perfusion. Okay. Then
Yes.
there will be a contradictory term because the anatomical dead space area, those parts, those trachea, the major bronchi, bronchioles, all of them are receiving their own blood supply for survival. We have a tracheal artery present, we have the bronchial blood supply present, and those bloods are only draining past what is called the physiological shunt. Okay, they are going in directly draining into the heart. Right. So that last part of your answer in definition due to lack of perfusion can be removed to just say that it is that part of the ventilation which is not taking part in gaseous exchange. Okay, that is number one. And another important thing missing in your very beautiful presentation is you have not mentioned the calculation made by Bohr and then modified by Enghoff, how to calculate this dead space. Did you not read
Yes,
about
sir.
that? Don't you think
Sir, actually, I thought it was just define and classify, so I thought I was not supposed to include that.
yeah, define and classify. How do you make out what is the percentage of alveolar ventilation? You said in normal healthy individuals it is negligible, but that doesn't mean that there is no alveolar dead space at all. So we should be able to calculate that, isn't it? So we must calculate the. You mentioned that. What is the? You know the equation, Bohr's equation, which was later modified by Enghoff. What was the original Bohr equation?
Sir,
Calculate the
I can't.
alveolar. Huh? You read it, but you don't remember. And anybody else who can help her out? How to calculate the alveolar equation to calculate the alveolar dead space? Rao, are you there? Right. I think you should mention that also. Okay. So that is also part of the dead space. And what happens to the dead space in exercise? In normal healthy individual, when you do a severe exercise, what will happen to the dead space? Will it increase or decrease?
Sir, it will increase since the perfusion will increase. The dead space will decrease.
Decrease. Yeah, it will decrease. Okay.
Decrease.
So, yeah, right. So anyway, I'll just show you a presentation where